Every year, 70,000 seniors die from strokes caused by controlled blood pressure. Controlled, that word should terrify you. But new research shows the number doctors are aiming for may actually be harming you. Not helping you, harming you. In the next 20 minutes, I am going to show you the specific target range that protects your brain at your age. Stick with me, because what I am about to share contradicts what most doctors are still telling their patients today. I am not going to give you the answer right away. I know that is frustrating. But if I skip to the number without explaining why, you will not believe it. And you need to believe it because your life may depend on it. By the end of this video, you will know 3 things. First, why the blood pressure range you were given is based on studies that excluded people your age. Second, the specific physiological reason your aging arteries need different numbers than a 40-year-old's. Third, the exact target range backed by the latest senior-specific research and what to do with that information today. Before we go further, comment below and tell me this. What number did your doctor last tell you to aim for? I want to see what you are dealing with. As a cardiovascular physician, I have worked with over 4,000 patients facing this exact problem, and the pattern I keep seeing is not random. Let me tell you about Margaret. Margaret is 68 years old. She comes into my office with a blood pressure log she has been keeping for 3 months. Every entry is between 118 and 122/75. Perfect numbers on paper. She is taking 2 medications, eating low sodium, walking 30 minutes every morning, and avoiding caffeine. She is doing everything right. Everything. And yet Margaret has had 2 episodes of dizziness so severe she grabbed the wall to keep from falling. She stopped driving after dark. She gave up her Tuesday morning volunteer shift at the library because she was afraid something would happen while she was alone. Her daughter had started calling twice a day. That is what this costs. Not just a number on a cuff, it costs independence. It costs dignity. It costs the quiet confidence of knowing your own body is safe. Margaret sits across from me and says, "Doctor, I am following every rule. Why do I feel like I am disappearing?" That question stopped me cold. I pulled her chart. I reviewed her medications. And then I looked at her imaging. Her carotid arteries showed moderate stiffening, common in women her age. And I realized the target we had been chasing, the target her previous doctor had praised her for hitting, was almost certainly starving her brain of blood flow. That is when I realized the guidelines were wrong for people her age. Not slightly off, structurally, fundamentally wrong. Think of your arteries like a garden hose. When the hose is new and flexible, low water pressure is enough to reach every corner of the garden. When the hose gets stiff and narrow, you need more pressure just to push water to the same distance. Your arteries work the same way. At 65 or 70, your arterial walls have thickened. The smooth muscle inside has stiffened. The elastic fibers that once stretched and rebounded with every heartbeat have calcified in places. This is not disease, this is normal aging. But here is the thing. The blood pressure guidelines most doctors follow today were built on studies conducted primarily in people between the ages of 40 and 60. When those guidelines say 120/80 is optimal, they are describing optimal for a middle-aged cardiovascular system, not yours. A 2019 study in the Journal of the American Medical Association followed 9,300 adults over the age of 65 for nearly 4 years and found that those treated to a systolic target below 120 had a 21% higher rate of serious adverse events, including fainting, acute kidney injury, and dangerous drops in blood pressure. 21%. That is not a small signal. That is a warning. But most cardiologists trained before this data came out are still running on old programming. Now here is where it gets interesting. Your brain is the organ most affected by this. The brain of a 68-year-old has already experienced some reduction in its autoregulatory range. That is the biological term for the brain's ability to maintain constant blood flow despite changes in pressure. In a younger person, the brain adjusts beautifully across a wide range of pressures. In your brain, that range has narrowed. If your systolic pressure drops below a certain threshold, your cerebral perfusion drops with it. Blood flow to the brain becomes insufficient. You feel dizzy. You feel foggy. You reach for the wall. Most people believe that lower blood pressure is always safer. They believe this because for decades, every public health campaign, every doctor's office poster, every television commercial reinforced that message. Lower is better. Aim for 120. Get it under control. But here is the problem with that. That message was never calibrated for aging arteries. It was a one-size-fits-all recommendation applied to a population it was never designed to protect. The researchers who built those guidelines were not trying to harm you. But the guidelines outlived their evidence base, and nobody updated the prescription pads. A 2021 study published in Hypertension, the Journal of the American Heart Association, specifically examined adults aged 60 to 80 and found that a systolic target between 130 and 145 was associated with the lowest risk of combined cardiovascular events and cognitive decline. 130 to 145. Not 120. Not 115. The range your doctor may be pushing you below actually showed increased risk in this population. That data has been available for years, and yet the standard talking points have barely changed. Let me be very clear about what is happening inside your body when your pressure is pushed too low. Your kidneys, which already have reduced filtration capacity as a natural result of aging, depend on adequate perfusion pressure to function. When systolic pressure drops too far, kidney function deteriorates. Your kidneys then retain more sodium. Sodium pulls water into your bloodstream. Your heart works harder to pump a higher fluid volume. Your pressure goes back up. Your doctor increases your medication, and the cycle continues. This is not a mystery, this is physiology. But it is physiology that gets lost when a doctor has 7 minutes per appointment and a guideline that says aim for 120. And here is what terrified me most when I dug into this research: the cognitive connection. A 2020 study in Lancet Neurology followed 7,000 adults over 70 for 36 months and found that those with systolic pressure consistently below 125 had a 34% higher rate of cognitive decline compared to those maintained between 130 and 150. 34%. This is not about heart attacks anymore. This is about whether you remember your grandchildren's names in 10 years. This is about whether you stay sharp, stay present, stay yourself. Now here is where it gets even more specific. The mechanism is called cerebral hypoperfusion. It means insufficient blood delivery to brain tissue. It happens silently. You do not feel it as pain. You feel it as fatigue that does not lift, as words that take a half-second longer to come, as a morning fog that used to clear by 9 a.m. but now lingers until noon. If that description sounds familiar, I want you to hear this clearly. That is not aging. That is not inevitable. That may be your medication doing exactly what it was prescribed to do, hitting a target that was never right for your age. This is why arterial age mismatch is the real cause, not high blood pressure, not insufficient medication. The mismatch between a guideline built for a younger cardiovascular system and the specific physiological needs of arteries that have been working for 6-7 decades. So here is exactly what I want you to do. First, at your very next appointment, ask your doctor one specific question. Ask them, what is the evidence base for my current blood pressure target given my age and arterial stiffness. Write that question down, bring it on paper, ask it. Their answer will tell you a great deal. Do this before your next medication adjustment, no matter when that appointment falls. Second, for the next 30 days, take your blood pressure twice daily. Once in the morning, 10 minutes after waking, before coffee or medication. Once in the evening, seated quietly for 5 minutes first. Record both numbers every single day. Do not average them in your head. Write them down. Bring that log to your doctor. A single office reading tells almost nothing. 30 days of home readings tells the truth. Third, if you are currently experiencing dizziness, brain fog, unexplained fatigue, or falls, ask your doctor specifically about a medication review for orthostatic hypotension risk. That is the technical term for blood pressure that drops when you stand. It is directly linked to overmedication in seniors. Tell them you want that evaluated. You have the right to ask. You have the right to an answer. This is your 30-day challenge. 30 days of twice daily readings, written down, brought to your doctor. 30 days of asking the right question instead of accepting the standard answer. 30 days of being your own advocate, armed with real data instead of fear. Your brain will thank you. Your kidneys will thank you. Your future self will thank you. Now I want to know where you are in this. Comment one of 3 things. Comment A if you are currently medicated and hitting the 120 target but still feeling symptoms. Comment B if you are over 65 and your doctor has never discussed age-specific blood pressure targets with you. Comment C if you have already pushed back on your doctor and want to share what happened. I read every comment. I want to know what you are dealing with. If this video helped you see something that was hidden in plain sight, subscribe. Not because I post often, because when I post, it is because something in the research has shifted and you need to know about it before it reaches your doctor's continuing education newsletter 3 years from now. You deserve information at the speed of science, not the speed of institutional inertia. And before you go, I need to leave you with one question I did not answer today. We talked about the target range. We talked about the mechanism, but we did not talk about which specific medications are most likely to cause dangerous drops in elderly patients, and which ones have the most senior-specific safety data. That is the next video. And that information changes everything about how you evaluate your current prescription. You are not broken. The guidelines failed you. Now you know the truth.